Good morning, everyone. It's wonderful to be here. My name is Zachary Eisner. I'm a researcher at the University of Michigan, and today I'll be talking about repurposing transportation providers to provide emergency medical services in specifically low and middle income settings in Asia during the COVID-19 crisis. Before we begin, I just want to give a few personal disclosures. I am the operations director of a nonprofit organization called LFR International that I'll be talking a little bit about today, as well as a researcher for the Michigan Center of Global Surgery at the University of Michigan. If you guys are interested in following up for any reason after this presentation, below you can find my Twitter and email, and I'll also have those on the end slide at the end of the day. So please reach out if you want to collaborate on any of this work or talk more about it. So before I get started on introducing the lay first responder model, I want to talk a little bit about injury and specifically how injury contributes to the global burden of mortality. So first of all, injury contributes to about 10% of the world's deaths. However, 90% of these deaths occur in low or middle income countries. You can see that stark difference there. Additionally, road traffic injuries are the single greatest contributor to this global injury burden. And you can see here down in the right corner of my screen that this has really become a greater issue in the past 30 years since the 1990s, mainly because industrialization and motorization have driven a lot of the injury burden that we're seeing today. Emergency medical services may be used to address this, and we can see that about 80% of injury-related deaths occur in the pre-hospital setting in low and middle income settings, whereas this pre-hospital death rate is only about 59% in high income settings. And so the contrast there makes evident how important EMS is to averting these pre-hospital injury deaths. It's also been hypothesized that about 45% of all deaths in injury can be addressed by emergency medical services. However, we've seen that attempts to replicate emergency medical services from high-income settings have failed in resource-limited settings, mainly because of financial limitations, limited infrastructure, both road infrastructure and transportation infrastructure, as well as lack of health insurance or lack of robust health insurance networks. Additionally, we've seen that EMS development throughout resource-limited settings has been heterogeneous and varied. There hasn't been one single model that's been adopted or a consistent model that's been adopted across resource-limited settings. We also know that in 2004, the WHO recommended that these lay first responder programs or bystander training programs be the first step towards formal emergency medical services development. So what this means is they had recommended to the general public that training should occur of lay people who are not medically trained, to provide these emergency medical services. So at LFR International, the nonprofit that I work with, we have developed a model called the lay first responder model of emergency care. And what this is we've trained motorcycle taxi drivers and transportation providers to serve as these lay first responders and provide emergency care. We've done this in several study locations across sub-Saharan Africa, as well as Guatemala. But it's our hope that we can expand this globally, especially into the Southeast Asian setting, where the need may be great for such models. In order to do this training, we use 6 main curricular categories. And these are 6 curricular categories that we've distilled to be the highest yield functions in areas of trauma. So first of all, we talk about principles and definitions of first aid. What does it mean to be a first responder? Then we talk about scene safety, body substance isolation, personal protective equipment. And this is potentially an area of the course that we'd like to augment for COVID-19 safety, adding additional components to scene safety. We then also talk about airway, breathing, and circulation, the classic ABCs of survival. And we also talk about fracture splinting. But most importantly, we discuss with the first responders victim transport and how to safely move victims between facilities or from the pre-hospital setting to the hospital setting, using their pre-existing transportation networks. It may be motorcycles or tricycles or taxis, but we can leverage these transportation systems to provide emergency care without purchasing expensive box ambulances and developing that infrastructure that is very costly in high-income settings. We've seen that through this curriculum, there's significant knowledge acquisition before and after the course. So you can see there on the bottom row, we have about a 40% increase in knowledge acquisition before and after the test, the course on a pre and post test. And you can see that about 61% of that is maintained after 6 months. However, after about 9 months, we see knowledge retention drop to only about 44%, indicating that refresher trainings are indicated between the 6th and 9-month mark. We've also seen this to be very cost effective at only about $6 per responder. That incorporates both first aid kits with basic trauma supplies and personal protective equipment, as well as training costs such as trainer salary, training space, and even food for first responders during their training sessions. Like I said earlier, this has been shown to be highly cost effective because as we calculate it out, we can see the cost for 100,000 people covered by this care to be only about $12,000. And that's using disease control priorities recommendations that about 0.5 to 1% of any given population is trained as a first responder in order to provide adequate coverage. So for an area of 100,000 people, we'd want to train approximately 500 to 1,000 first responders. Then we can go ahead and look at this cost effectiveness calculation done here. And this is what we've done by calculating the disability adjusted life years averted due to a lay first responder program. And we found that about $54 is the cost of each daily averted, which as per the WHO choice guidelines is defined as highly cost effective. And so we've turned something that has been completely infeasible because of the high cost into a model that may actually be cost effective for resource limited settings. Longitudinally, this folds up in patient encounters as well. Over 3 study locations, we've seen that lay first responders provided patient care in almost 2,200 encounters, of which almost 93% were transported exclusively by motorcycle. And this is including contraindications to motorcycle transport, such as altered mental status or anything that would prevent somebody from sitting up on a motorcycle, such as double lower extremity fractures, pelvic fractures, or spinal injury. We've also seen a social and economic impact of training lay first responders. In both a 3-year follow-up in Uganda and a 12-month follow-up in Chad, lay first responders experienced a drastic increase in their weekly salaries by almost 25%. And this is due to a mechanism we hypothesize to be the social impact and the community impact of a lay first responder. As you can see through this testimonial at the bottom of the screen, this first responder said, "I'm trusted and respected by those that know about the training I received in first aid." And so what we've seen is people are actually seeking out these transportation providers, these motorcycle taxis, who have been trained in first response because they see them as more socially responsible providers, and they would like them to take their family members or their kids to wherever they need to go, whether that be school or daycare, whatever it is. These people are being sought after. And this is because the incidents where they're becoming involved as first responders are very public. There's a road traffic incident, and people will gather around and see the first responder provide that care, remember who they are, and say, wow, that's the person that I want to be taking my family members where they need to go. We also see longitudinally that after a 14-month study in Sierra Leone using the pre-hospital emergency trauma care assessment tool, that about there was a 4 out of 10 increase in the availability of pre-hospital care for people in the general community. And this was assessed by using the expertise of first-line hospital providers. And so we surveyed first-line providers in tertiary care centers around the study location, as well as a control location. And we're able to see there was a definitive difference in the availability of pre-hospital care due to these lay first responders. Now I'm going to switch gears a little bit and talk about how this model can specifically be applied to COVID-19 in Asian resource-limited settings. As a brief background, there have been about 70 million reported infections of COVID-19 in Asia since December of 2019, and there have been over 1 million deaths associated with these infections. There's also a high prevalence of comorbidities that increases the COVID-19 mortality, mainly in Southeast Asia. We've also seen significant barriers to COVID-19 vaccine access as compared to regions of high-income countries. And this really highlights the need for emergency medical services. One, because there's an increased need to transport those who are critically ill, either from smaller hospitals to larger hospitals with more care capabilities, or from the pre-hospital setting from their homes to the hospital setting in the first place. It's also shown that EMS provides a critical component of preparedness and responsiveness to major public health crises like the COVID-19 pandemic. So how do we repurpose the curriculum that I've been talking about to address COVID-19? Well, as I mentioned before, there's going to be two main curricular changes that need to be implemented. First, we'll need to augment the scene safety portion of the curriculum to talk about COVID safety specifically. What personal protective equipment is needed, what body substance isolation is needed, and how do you safely transport those who have been infected or potentially infected with the COVID-19 virus. And this applies to all trauma in addition to medical services, because in the age of COVID, it's important to practice good COVID safety in any setting. We also need to teach more about the introduction of infectious diseases and how those diseases are transmitted, how viruses work, virology, in addition to looking at the signs and symptoms of COVID-19 specifically. Lastly, we'll need to make some logistical modifications to the model for Asian LMIC settings. Ideally, we would be able to continue using motorcycle taxi drivers and tricycle drivers because of their wide prevalence throughout Asia, but we could also look at training taxi drivers and bus drivers. Additionally, because we're looking at COVID-19 response, which is less public than road traffic injury, we'll need to implement some sort of dispatch mechanism. We're currently undergoing trials with toll-free phone numbers and a smartphone app, specifically the Beacon SMS app, that allows first responders who have been trained to be dispatched directly to the site where there has been an injury or medical problem. And so this would be very useful for COVID-19 response. Lastly, in this presentation, I want to talk a little bit about the importance and ethical implications of Good Samaritan laws and why this is such an important first step to developing lay first responder programs and general emergency medical services in Asia. As a brief background, Good Samaritan laws are developed to encourage people, mainly first responders, to help others in emergency situations by granting them legal protection as long as they act within their scope of training. To date, however, there are only 2 nations in Asia that have some sort of formal, federally mandated Good Samaritan law, and that's China and India. And both of those are recent in 2017 and 2014, respectively. We've also seen through studies that have been done in India that 75% of surveyed individuals were hesitant to respond to others in emergencies. And of those individuals who answered the survey, 88% said that was due to a fear of the law. And so what this means is by implementing Good Samaritan laws, we know that we can very adequately address the concerns of these individuals who may not respond in the current state, but have the potential to be trained to alleviate this trauma burden. So in case anybody's thinking about Good Samaritan laws and how they could possibly suggest them and bring them to their community, I want to talk a little bit about 5 important features of a Good Samaritan law. Now, these are all not necessary, although some of them are very widely used. The first one is a duty to assist clause, and this defines the obligation of somebody to intervene in a case of emergency. A duty to assist clause would mean that somebody is required by law to help a victim if they are seeing an emergency, even if that's just calling for help. Not all Good Samaritan laws have this duty to assist. Secondly is the definition of imminent peril. And this is really important because it defines when somebody is and is not protected, specifically within the scope of when a victim's life is in danger. It's also important to enumerate that there's no reward or compensation expected for intervention under a Good Samaritan law. One other thing that some Good Samaritan laws include is an obligation obligation to remain. And this states that if somebody does decide to intervene within the capacity of the Good Samaritan law, they're required to stay with the victim until either a rescuer of equal or higher ability takes over, or the scene becomes physically unsafe for them. The law should be very clear that nobody is expected to risk their own personal safety in order to intervene. And lastly, perhaps one of the most important features of a Good Samaritan law is consent. And there's two branches to this. Number one, that a first responder must obtain consent from a conscious victim to treat him or her no matter what the circumstances are. And secondly, is that an unconscious patient is assumed to have implied consent, which basically means that if you're unconscious, it's a reasonable assumption to think that you would want someone to save your life. So these are some general points of Good Samaritan laws. Are active in resource limited settings.
What time is your class?
So just some conclusions really quickly. First, we can see, again, the injury burden.
My glasses, please, and on the...
Excuse me. We can see the injury burden is very high in resource-limited settings. Additionally, we've seen that pre-hospital emergency care is limited. However, access to care may substantially reduce this injury burden. We've also seen that training transportation providers such as motorcycle taxis or tricycle drivers provides a highly cost-effective means of providing that emergency care and expands pre-hospital care in resource-limited settings. These mechanisms also have been shown to have social and economic incentives towards them, providing sustainable involvement of lay first responders and low attrition rates. And these mechanisms are also very apt to be adapted for the COVID-19 crisis, specifically in Asia, because of high population centers. Lastly, Good Samaritan laws will aid in the widespread provision of lay first responder-based emergency medical services to those who need them. So thank you so much to everyone for listening to the presentation today. We are seeking additional study and program sites in Asia for large-scale implementation of these lay first responder programs. So if you or anyone in your community is looking to implement programs for emergency medical services, please reach out either to me or to LFR International as an organization, and we'd be happy to talk about setting up a project. Thank you so much. Again, my contact information is on this slide, and I'd be happy to answer any questions at this time.